We're excited to host the podcast Doctors Unscripted. We hope to bring interesting people together to have conversations about the future of health and healthcare. We hope by bringing different specialties, different leaders of different organizations together to talk about health-related topics, that you'll be able to find your own insights into our conversations. I'm Dr. Justin Thompson. I'm the CEO of Pain Doctor and Arizona Pain. Both of those companies focus on defeating the opioid epidemic by treating the root cause of pain. We hope that this podcast will be interesting to those people that are either interested in healthcare or on their own health journey as they seek to improve their lives. Today we have Dr. Zaman Mirzadeh, who's a neurosurgeon out of Barrow Neurological Institute. He's not only a neurosurgeon, but he has his PhD in neural stem cells. It was so fun to have him on and to go through our conversation today. He's someone that we send a lot of patients to specifically for his expertise in neurosurgery on complex neurological pain conditions. Today in our conversation, we went through a couple of different topics that I found fascinating. We talked about the technology that's coming down the line that's really going to change and impact healthcare, as well as the neurology of pain and even Ozempic. So hopefully you enjoy our conversation today. All right, so today we're lucky to have Dr. Zaman Mirzadeh here with us. Welcome to the podcast.
Thank you. Thanks.
So first off, Dr. Zaman Mirzadeh is, I'm just going to say Dr. Mirzadeh. He is a MD, PhD, and he's a functional neurosurgeon. So starting off there, that's a lot of initials after your name and stuff like that. What is a functional neurosurgeon?
You know, neurosurgery is a specialty in medicine where we take care of diseases of the brain and spinal cord, and we do that through surgery as opposed to what neurologists do, which is through medicines. And functional neurosurgery within neurosurgery is a division where rather than deal with structural problems like a brain tumor or a vascular malformation or some sort of disorder of the spine, we're treating the nerves and the brain, usually with devices, to try to improve the function of those nervous circuits rather than, remove a tumor or, change the shape of the spine, things like that.
So what type of patients is that, generally speaking, that you're going to see?
The three kind of main parts of functional neurosurgery there are functional neurosurgeons that deal with epilepsy. Mm-hmm. So that's one patient subgroup. There's another subgroup that deals primarily with movement disorders. So think like Parkinson's disease. And then the third subgroup are people that deal with patients with chronic pain.
Yeah. Which is what you focus on more.
Yeah, and exactly.
So let me ask you this. So your background, your schooling, I know a lot of people don't even know what goes into being a surgeon, let alone a neurosurgeon. So how many years of that at school did you do?
Yeah, it's a lot of school. Most of it doesn't feel like school. It mostly feels like an apprenticeship, the latter half. But, so after high school, it's 4 years of college, and then 4 years of medical school. I was very interested in research, so I did additional research as part of my medical school. So for me, it took 9 years to do my medical school and graduate school training, and then the residency for neurosurgery is 7 years. So I guess the fastest way to get there would be 11 years after college. It took me 16 years after college.
So you got your PhD before you went and did your neurosurgery residency?
Yeah, correct.
Oh, wow.
Yeah.
And what is your PhD in?
My PhD is in neural stem cells.
So in essence, you took what would be considered, I think, the longest amount of school you can possibly take in healthcare. Is that right?
Yeah. It's a longer road. I don't regret it at all because I really enjoyed for example, the PhD years. Part of what I do now is fairly intensive research. My career path has followed that trajectory. If one's not interested in doing research and wants to solely do clinical medicine, then certainly that's not required.
You don't have to take that many years.
You don't have to do that. Yeah.
Just an overachiever there, right?
Yeah.
So you said your research is in neuro stem cells. Is that what you said? So what are some of the cool things you're finding in that?
So that's what my PhD was in. Now in residency, as I started to focus on functional neurosurgery, my focus went away from stem cells and more towards the types of research that functional neurosurgeons do. So that's understanding how different brain circuits work. So in functional neurosurgery, the core tenet is if you can understand how the brain works or a particular circuit works, and then you understand how that circuit goes awry in disease, then you can come in with tools to fix the way the circuit works to fix the disease.
Well, that's awesome.
Yeah, and the kind of a prototypical example of that is what we do with Parkinson's disease. Now there it's worked a little bit backwards. We didn't necessarily understand how Parkinson's disease works before we figured out that we could treat it. But now our treatment is becoming one way in which we're understanding how it works, because we're looking into, well, how does, for example, one thing we do in Parkinson's disease is implant deep brain stimulator electrodes. So we put these wires deep into the brain and we send electrical current to specific parts of the brain, and that helps patients with Parkinson's disease who have troubles with their movement to move better. And so we're understanding about the brain waves that control movement. They go bad in Parkinson's, and then how the stimulator is able to help fix those brain waves. So that's a typical example, but you can apply that to lots of brain diseases. So
that's that's super cutting edge, like some of the newest and I would think the coolest things out there. So I was just going to ask, so since you're both helping a lot of patients that are in chronic pain and in the functional neurosurgery space, but you're also a researcher, what are some of the coolest areas of research or the coolest technologies that are kind of coming into play that maybe most people don't know about?
One is to try to get more diseases treated by these approaches, right? So one approach is to say, let's look at other circuits, not circuits related to movement, and if we can understand those circuits, then maybe we can put a wire in those areas and try to rectify those diseases. So in that way, functional neurosurgery, the fact that we're putting these wires into people's brains gives us access to collect data to understand how these brain circuits work. So there's two ways in which we're doing that. One is something very basic that I'm interested in is how the brain understands what the peripheral blood sugar is, because I'm very interested in diabetes. And we know that the brain has important roles in how we control our blood sugar in addition to well-known roles of insulin. If we can understand how these brain circuits behave in response to different levels of blood sugar, then perhaps we can come up with new treatments for diabetes. So that's a very kind of leading edge area that's, there's absolutely no clinical reason right now to have patients with diabetes be seeing a neurosurgeon, but that's kind of where we're headed. The other more tangible one is in patients with chronic pain. So there are patients with very rare pain syndromes that are not treated by really anything else, medications, other types of surgical procedures. And in those patients, we also target their brain with deep brain stimulation to try to help rectify their pain syndrome, to reduce their pain. And in those patients, we're also studying the brain waves to see how they're different than patients that don't have pain, and to see when those patients are in pain, what do the brain waves look like, and how can we change the way they look to change the way the patients feel.
I know one of the places where we've got a chance to kind of work together is in the painful diabetic neuropathy place. Neuromodulation, using that technology you were talking about before, where we're trying to normalize those nerve circuits to where somebody who shouldn't really be feeling burning pain in their feet or their hands, normalizing that nerve conduction to where they don't feel that and they're able to actually get mobile again, start moving again. I love what you said as far as like a normal diabetic wouldn't see a neurosurgeon or a pain doctor or something like that. But with these advancements in technology, we're actually able to help this chronic condition in a different way than people have done in the past.
For sure. Yeah, no, that's a good point. Yeah, and actually that's a good point of clarification. We are seeing diabetics, but we're seeing them for their pain condition, or we're seeing them for pain syndromes that are complications of long-term, high blood sugars. But I think, one fascinating thing is there might be a day when we're actually even helping them with their blood sugar, not just their pain. Yeah.
So is that going to be through stimulation of trying to change insulin release, or what do you feel like will be the mechanism there?
To be honest, I don't know. I mean, one potential is that we could come up with devices that control insulin release. Now, this is ways into the future. So, for example, we know that the parts of the nervous system that control things like your heart rate, your blood pressure, your ability to regulate your body temperature, these are the autonomic part of the nervous system. So those nerves also densely innervate organs like the pancreas and the liver that control blood sugar. And so we know that through that innervation, the brain does have control over how much insulin can get released.
Yep.
In the same way that the brain can control your heart rate. So, but figuring out how to manipulate those circuits is a more difficult task. We know that that happens endogenously, in people. We just don't know yet how we can kind of engage those circuits in a way that's safe and efficacious. So.
I mean, I think a lot of people may not understand. A lot of people do, but like every system in our whole body is controlled by nerves.
Yeah.
Right? Like when we think about that as like, oh, I need to move a muscle or something like that. Yes, of course that's nerves, but like the pancreas releasing insulin, like you said, or your stomach producing acid, or the motility of your gut. All of this is nerves, and so when nerves have issues, they can affect the underlying organ, right?
Correct. Yeah.
Your heart. Maybe that's a bad example, but it does fire based off of neurology as well. And so like when you're having these issues, through really understanding how neural circuits work, we're getting, as you said, this underlying view of almost every system of the body. And actually, I'm a believer in that type of area of research that you're going of. I feel like it could have some real dividends for improving healthcare. Mm-hmm. The better we understand that, the more we can actually help conditions based off of faults in neurology rather just than in, let's say, pathological disease of the histology. Right. So I think it's a really cool place to research. So that's fascinating to me. Let me ask you a question on the diabetic space. So right now, obviously, Ozempic and drugs like that are incredibly popular. We're seeing that just explode. And people don't fully know the side effects of what's happening, but I have seen people talking about, as I should say, research and people starting to look into Ozempic for brain function, Ozempic for diabetes.
Yeah.
Right. So, do you have to deal with any of that type of stuff as you're working with some of the diabetic stuff?
Yeah. So it dovetails really well with the things we're doing. So, the weight loss effect of Ozempic is almost certainly through action on the nervous system. There are GLP. So Ozempic is what's called a GLP-1 agonist. So GLP-1, there are receptors for GLP-1 all over the brain. There's lots of receptors for GLP-1 on the brain. Now, GLP-1 also binds to receptors in the pancreas. And so initially it was, a treatment that was, investigated for diabetes because it has a powerful effect on the pancreas to increase insulin release. But then it has all these other effects through all these other target organs, the primary other one being the brain. Yeah. Mm-hmm. And so by acting through the brain, that's almost certainly how it has its weight loss effect, is through effects on the brain. Now, interestingly, there are GLP-1 receptors in lots of different brain areas that control different things, and specifically for the weight loss effect, control different, or have different effects on appetite. And so there are GLP-1 receptors that affect appetite in an aversive way, and ones that affect appetite in a non-aversive way. So one of the main side effects, one of the intolerabilities for some patients on GLP-1 is that they don't like how it makes them feel. And some of that may be because of its action on the aversive appetite suppression centers. But we know that there are non-aversive appetite suppression centers. So there's active drug research right now looking at modifying Ozempic so that it's non-aversive only, so that it only targets the non-aversive appetite suppressive centers. So all of this is, an evolution, and Ozempic is sort of the first big breakthrough. I mean, people have been studying GLP-1 and GLP-1 agonists for a long time, and finally this drug has, borne some fruit from all that work.
That's super cool.
Yeah.
So let's talk for a second about, how did you end up getting into healthcare? So obviously you picked the longest route you can possibly do through medical school, but there had to be something initially that made you interested in this field.
Yeah, I think for different people it's different things. For me, it was I was really interested in the science first, but the science kind of takes you so far, and then you definitely have to like taking care of people. For example, I have classmates who were, also MD, PhD, and who, decided that the science was the more interesting thing for them rather than the clinical practice, and so they practice less clinically and are more heavily in the science. But I think for, really the essence of a physician is that feeling of wanting to take care of people. And,
Agreed.
You have to, study a lot of science and understand diseases and as far as we do and how to treat them. But the core of it is taking care of people. And if that part's, not enough of interest to you, then it's not worth it, and you won't kind of I think succeed. So
Do you ever find yourself kind of caught between those two of loving your research and getting fascinated and then going, but I also love the patient care and like helping patients seeing those outcomes, and sometimes go, which one of these, do they compete for you?
Yeah, it's interesting. They used to compete more for sure. Lately, just this is my own personal, everybody has their own kind of journey through it. My own personal journey has been that more and more the research I'm interested in are the areas that are the closest to translation or can really potentially make an impact in a shorter term. Through my PhD, I was studying things that were definitely important, but the impact on kind of human health was a long ways away. So, maybe generations away. Whereas the things
stay interested sometimes.
Yeah. So now I've become more interested in things that I think are more immediately impactful. So, I think that diabetes is one of those. That's one that, we could potentially change the course of thinking about the disease within a generation or so.
So when you say within a generation, we're talking next 10, 20 years? Or?
Yeah, I hope so. I hope that in the next 10, 20 years that as our understanding of the brain's control of blood sugar, becomes more pervasive and more widely accepted, that there will be more therapeutic strategies aimed at the brain, like GLP-1. I mean, one of the reasons GLP-1 probably works so well, in addition to its action on insulin, is that it has a clear action through the brain. So there's, including for the ways that it controls diabetes, is that we know that in part the effect of GLP-1 is mediated by actions of the brain that do not depend on insulin. So that may be why it's been such a good drug, is because it hits both of these targets.
Both of them.
Yeah.
Let me ask you this, because I feel like we get this question a lot. Can you talk to maybe the changes that are happening neurologically to somebody who has painful diabetic neuropathy, right? So they have diabetes. How come that turns painful for some people and not for others? And when it does turn painful, what's going on?
I can't speak to it with any kind of expertise other than what I've learned, like in medical school, which is that, persistently high levels of blood sugar lead to, glucose causes these changes in proteins that are in the nerve cells and in the blood vessels, and leads to, for lack of a better term, a neuropathy, which just means like some disease of the peripheral nerve. So in some way, that persistently high levels of blood sugar leads to nerve damage in those peripheral nerves, such that they're now no longer able to do their normal function, which is to
sensory tests,
which is to do sensory stuff. And then as you lose that kind of ability to do sensory stuff, some of the other things that those nerves do is to regulate pain in those areas by, if you have a normal sensation in an area, usually that dampens a painful sensation from that area. So if you start to lose the normal sensation, then you lose that inhibitory control on the pain, and so then the pain kind of gets out of control. Yeah. Pain is almost like the default state in the absence of normal sensation. This
is why as kids, like if we hurt ourselves, we like rub our pain, like you bump your elbow and you rub it. It's because when you're firing those sensory nerves, then you're actually overriding the pain signal, and when you can no longer have those sensory nerves firing and feeling like proprioception or the ground or anything like that, the only nerve that's firing is the pain. That's all you're feeling. Is that right? That's the theory. I mean, I think it's got various degrees of support,
but it's a really good conceptual way of thinking about it, which is, and that it's called like the gate control theory, which is that you gate the pain with normal sensation. So
that's super interesting.
Yeah.
So let's talk about healthcare in general. I feel like one of the biggest problems in healthcare is the fragmentation that we have in healthcare. And unfortunately, while we have some of the best doctors in the world, I feel, in America, oftentimes patients don't know who they should see, right? And so let's say somebody that's in pain, right? They go, okay, should I go see my primary care? Should I see a pain doctor? Should I see a chiropractor? Should I see a neurosurgeon? Should I see an orthopedic surgeon? Should I see a physical therapist? So there's like all of these options. And the patient oftentimes says like, I don't know where I should go. So for a neurosurgeon, compared to, let's say, an orthopedic surgeon or a pain doctor, when should patients be looking to come see you?
We're definitely sort of a referral center, so we are not like a primary source, because for all the pains that are out there, I still think a very small minority of patients need any kind of neurosurgical counseling, or even less than that, an actual operation. So yeah, I think, starting with like a good primary care provider who understands that there are multimodal ways of treatment, and then can help guide that patient to the things you said, physical therapy, chiropractor,
pain management.
Yeah, I think to me, like those are the gradations. Is you start with, well, let's not do anything that involves concentrated chemicals. Let's just start with movement. And then if movement doesn't work, or proper movement, learning how to move your body correctly, then okay, let's do some concentrated chemicals, and you can do that orally. And then the next level up is you can do that through an injection with pain management. And then it goes up from there, and on that scale, surgery is kind of at the end of the line for pain. We get involved more early in the process if there's a neurological deficit. So we're okay with patients being in pain and saying, we want them to pursue more conservative things like all of the things I mentioned. Pain management, physical therapy, chiropractor. We're okay with that so long as pain is the only symptom. But as soon as patients start to develop more numbness or weakness, that's when we want to get involved more early. And the reason for that is that those problems don't necessarily go away after surgery. So once you have developed the deficit, it may be permanent. And so we want to intervene so that it actually doesn't get worse, and hopefully it gets better.
So talking to that though, do you ever get frustrated with kind of that fragmentation of information? Wishing patients got to you sooner so you could have helped more?
But yeah, I think it goes in both ways. Exactly. Like sometimes, we see patients after they've been, at something for months or years, but they had a deficit very early on, so they haven't been able to move their foot for 6 months, but they've been undergoing pain treatments to try to help. I think that's happening less, at least in our community. It seems people seem to be pretty good about seeking the appropriate help when there is a deficit. The reverse is also true, where sometimes I see patients that definitely don't need to see
way
me.
Too early.
Yeah, because and then the patients are very frustrated because usually it takes a while to get in. So the patient's been waiting for a month or so to get in to see us, and then they come to see us only to hear that, well, I'm not sure why you're seeing us. I'm sorry, I can't help, and it feels very defeating for the patient and for me, because I understand that they've been waiting, and it's not good for me to feel that now we have to, get them to the right place. Or
I know that's something that we see. I also find it really interesting that we've seen, I feel, an awakening in America to where we have this opioid epidemic, over 100,000 people dying every year from opioid-related issues, right? And the research shows that the majority of those started with a prescription opioid. That's not necessarily what killed them,
right?
But they started their addiction and their process of decline from a prescription. And so I love your recommendation saying, if we don't have to use concentrated chemicals, or in essence prescriptions,
Yeah.
right? Like that's better. And for a long time, I feel like it was so easy to say, I'm in pain, give me a pill, you know?
Right.
And I feel like that's how we got to
Yeah.
where we are. Whereas now there's people saying, you know, I don't want to be on those drugs. I don't like. I'd like to see if I can do something before then.
Yes.
Which is one of the reasons, you know, we do the physical therapy and chiropractic as part of our practice, is because bringing that in, and we often hear this related to as a care funnel, right? Of coming in the top of, you're going to try those conservative therapies, and you're going to see, can chiropractic, can physical therapy, can physical modalities give you the relief you're looking for? And if not, what does that escalation look like? And moving into med management. For a long time, we did not do some of the med management. We did chiropractic, physical therapy, and then we did interventional pain, which is more of, you know, the intervention and injections and surgeries. And what we saw is, you know, our goal was to defeat the opioid epidemic. And we saw that if we weren't treating people that were suffering from the opioid epidemic, how are we going to defeat the opioid epidemic? And so we had this pride of saying, you know, well, we're not putting people on opioids, so therefore, you know, we're stopping it before it gets there. And we were doing a really good job in helping a lot of people. But eventually what we saw is there was a whole bunch of people that were on opioids, and there was nobody that was helping them to get off of them by offering other modalities and other things to get them back to living the life they want to live. And so that was a huge change for us of integrating that in, but so that patients could have that more continuum of care, the communication, and defragmenting the model. And we've loved working with you. So Dr. Mirzadeh is at Barrow's, and we've had an amazing relationship of sending patients back and forth and stuff like that. But I do think that it can be confusing for patients when they do end up too soon, or they shouldn't be there to you. So what happens when they do end up, and you're in that conversation, and there are patients in front of you, and you need to send them somewhere else? Like, what's your normal process and conversation go like in that situation?
I try to show them what I look at, which is the imaging. You know, as surgeons, we rely heavily on, you know, imaging, and there has to be a sort of a surgical target that we're going to do something about in surgery to fix the problem. So if I can show them their imaging and show them that on their imaging I don't see a targetable problem. If there's no targetable problem, it's not that I'm saying they're not in pain. It's that I don't see where their pain's coming from based on all the tools I have to evaluate. And so if I can't see anything wrong on the X-ray or the MRI, then I don't even know where to cut to make a difference. And so I just try to walk them through that you know, and in some ways I also try to tell them to reassure them, you know, that is reassuring, because yes, you're in a lot of pain, but in some ways it's good that at least your pain at the moment doesn't reflect some underlying, you know, really bad thing that's happening on your MRI. And so we should be able to get your pain under control, but it's not going to be a surgery. And then, you know, depending on the patient and exactly what their problem is, then I try to redirect them, you know, back to pain management, or it's to, you know, let's say neurology, if it's a more nuanced neurological pain, as opposed to sort of like an arthritic type pain. So, you know, for example, patients with migraines. Now that the neurologists have lots of great, you know, migraine drugs, and so those patients might, you know, be better for neurology as opposed to pain management. Whereas the neurologists are fairly limited in their approaches to pain. So the wider breadth covered by pain management, you know, captures basically a lot of those patients.
I mean, so it's like a double-edged sword, right? If a patient ends up in front of you, it's like, I can either help you, or if I can't help you, it's okay. That's a good thing.
Yeah,
like that means it's not so bad that it needs to be dealt with surgically and stuff like that. And so even though it's frustrating, I mean, I think from a patient's perspective, that can also be comforting. I thought this was going to be worse, and yet there's other things that maybe are not so invasive that can treat this.
Right.
So let me switch directions on you for a moment. So I know that neurosurgeons and orthopedic surgeons do a lot of procedures that are very similar. In some cases, the exact same procedure. This is something that we get asked a lot by patients of, like, who should I see? Should I go to a neurosurgeon or orthopedic surgeon? So talk to me, what, in your opinion, what's the main difference between like the orthopedic surgeon versus a neurosurgeon for a patient?
We have different paths to getting there. I mean, I think the overlap between neurosurgery and orthopedic surgery is really spine surgery. So orthopedic surgeons don't take out brain tumors, they don't treat brain malformations, they don't take out tumors out of the spinal cord, they don't really go into the dura, the membrane that covers the spinal cord at all, which is also in the spine, right? So within the spine, the sort of area that's the always been and continues to be the neurosurgeon's area is the spinal cord and the nerves and what's inside the dura. Now, when you get outside of the spinal cord and the dura, to the bones and the joints and the facets and all the things that typically are related to degenerative spine disease, that's where there's a ton of overlap, because neurosurgeons treat those sort of, let's say, bone and joint related disorders, and orthopedic surgeons do too. And it's just how the training gets you there that's different. So in neurosurgery, our training is all brain and spine. So in our training, we do lots of brain operations and we do lots of spine operations. The predominant spine operations we do are these bone and joint, fusions, laminectomies, decompressing, microdiscectomies, these kinds of things. Orthopedic surgeons in their training, they work with all the joints. So they do shoulders and knees and hips, but they also do spine. And so we come at the spine in different ways. And I don't think there's, necessarily a right answer, so long as the surgeon you're seeing is reputable and you have, let's say, good references for that person. So, I've sent my dad to an orthopedic surgeon in San Diego because I knew him and I knew he's very good. So I'm not,
biased one way or another.
Yeah, I'm not one to say like you only can see, you should only see a neurosurgeon. I think you just have to see a good surgeon. You can get good spine training, I think, from either direction.
So just to sum up some of the things you said, while ortho and neuro are both going to deal with the structure of the spine, only neuro is going to deal with the neurology of the spine, right?
Right.
Orthopedic's going to do the laminectomies just like the neurosurgeon is. They're going to do the microdiscectomies and the different things just like a neurosurgeon would. But as soon as we start going into the nerves needing to be operated on, or the spinal cord or the brain, like orthopedic stops, and that's purely the neurosurgeon's expertise. Is that right?
Yeah, exactly. Yeah.
I once heard, this is going to get me in trouble with some of my orthopedic surgeon friends. I once heard a neurosurgeon say the difference between going to a neurosurgeon and an orthopedic surgeon is whether you go to a contractor or a fine carpenter, like wood carpenter, of like the neurosurgeon's going to get really into those details and stuff like that, whereas the construction worker is going to build the house and they're going to be working on the frames. And I mean, I do see that sometimes in the OR of just the difference in tools. The orthopedic surgeons sometimes looks like they're doing construction. Whereas you guys are much more precise. Again, there's wonderful ortho spine docs, and I don't really put that down, but it was just one of the explanations that a neurosurgeon gave me.
Yeah, for sure. And I think that's that was definitely true in the past. Like there was more of a divide. I think there's much more understanding of cross-pollination and how each specialty has learned from the other.
That's awesome.
So yeah, I think it's there's lots of talk. I don't know that it will ever happen, but there's definitely talk amongst these circles of the people that control training programs of developing just a spine training program that's not ortho or neuro.
It's just spine.
It's spine, and so splitting spine off to its own thing. So, whether that ever happens, I don't know. But it's just to the point that there's a recognition that there are multiple ways to get there.
So let's ask this question. So we've seen in that space, there's absolutely been a shift for pain doctors. So interventional pain is becoming more interventional spine. Right, and so we're seeing a lot of minimally invasive surgeries that are coming out. What is your opinion on some of those minimally invasive surgery compared to maybe some of the more invasive surgeries that used to be there?
I think the key is the training. So it's understanding what is the ultimate, goal of the procedure, and how much, for example, decompression are you achieving through a minimally invasive approach. So for example, in our field, when minimally invasive approaches, started to come about with, using very small incisions and tubes rather than bigger incisions where everything was widely visible. So when you're looking through a tube, the criticism was always, well, can you get the decompression you need if all you're seeing is, through this tube?
Just focus there.
Yeah, through like a little telescope. And then and it became clear that no, you can, because look at how you can angle the tube in different directions, and people became very good at using tubes to get the views they needed within limits. You still couldn't do as much if you had, let's say, multiple levels to do. Then at some point it becomes diminishing returns, and the advantages of the minimal approach go away. But that's what I'm saying is, so long as there's evidence that you achieve decompression, and you get imaging and you can see that you've actually accomplished the goal, then I think that's where I think minimally invasive approaches have found favor, is because people have seen, well, you can get to the same point with a shorter recovery.
Yeah,
so.
And that's the main thing, is the recovery time being shorter, getting back to your movement's so important to life.
Right.
And so the more downtime we have, the harder the recovery can be, and therefore the higher incidence of complications and side effects and so on and so forth, right? And I think that's one of the big draws for minimally invasive is, back to function faster.
Yeah.
But there always is that question, well, is it going to be as effective? And so generally you're saying there's a lot of great minimally invasive procedures that can be helpful, but it depends on the circumstance of whether it's the right route to go.
Right, exactly, yeah.
Okay.
Yeah.
So let's go to this is another thing that you mentioned earlier, I just want to touch base on. So the different severities of neurologic issues. So in the pain space, right, people think that pain is the worst neurological. Like, if I'm having pain, that must mean that that's really, really bad.
Right.
But in reality, that's not the case, right? People go, well, I have numbness, so it's not so bad yet. Like, it's only numbness, I don't have pain, so therefore I don't need to worry about it. Or it's just a little bit of weakness, and so it's not so bad because I'm not experiencing pain, it's just weakness. We know that's not the case. So I'd love if you could talk a little bit about that.
Yeah, I think for us, again, it comes down to kind of the kind of functional loss. So pain is pain can be very debilitating and make someone very dysfunctional. It does it indirectly. So if I'm in pain, then I can't move as much, or I don't want to do as much. But it's an indirect effect. Whereas, so for me, pain is kind of a first level. It doesn't mean that it's not important, or that it's not more kind of troublesome for the patient even than if they were numb. Yeah. Right. So yeah, for most patients, pain is probably worse than numbness. But as a physician who's also interested in treating the nerves, we want to take care of the person's nerves. That's kind of our job, in addition to taking care of the patient as a whole. Is numbness to me is a sign that a nerve is definitely being impinged or damaged, whereas pain can be coming from multiple sources, one of which can be a nerve being pinched. Yeah. So once it gets to numbness, now we really know we're clearly in the realm of neurology and nerve dysfunction. And then the next level up from that is weakness. And the only reason weakness is even more important to us than numbness is because that's going to affect you more functionally. Yeah. Because you can still usually move fairly well if you're numb, unless you're having profound numbness, for example, in both feet. People that have numbness in both feet have a hard time walking. But if you have some numbness, it's usually not as disabling as if you are weak in an area. That means you can't use that body part. Yeah. So that's kind of how I think of those gradations. But again, in talking to patients, we do treat patients that have no weakness or numbness and only have pain. Yeah. But at that point, we've sort of demonstrated that the pain is very disabling, and that less invasive things have not worked. And so that's when we. Yeah.
So pain is always going to be transmitted neurologically, but that doesn't mean that there's pathology of the nerve.
Right.
Right. Whereas if there is numbness, we now know there's pathology of the nerve. Exactly. Right. And so that's that different level. If a patient comes in pain, there's a lot of different things that could be causing this, and there's a lot of different treatments that can be there. it's transmitting along the nerve,
Yes.
that doesn't mean the problem is the nerve.
Correct.
Whereas as soon as we go to that tingling or weakness, we now know there's more direct neurological considerations that need to be had and everything in the treatment. And so when patients come in, I would just say patients need to take pain seriously, but they also need to take those numbness and weakness. And that's where we sometimes encourage patients of, hey, education is really important here, of if you have numbness, it's really important to get that looked at, right? If you've got this muscle weakness or muscle wasting, even worse, that's something you should look at. It's not just saying, like, I'm getting older, so my muscle's wasting on this right leg worse than my left. Like, no, you should talk to a doctor about that, and that's one of the best things you can do is get it looked at. If the doctor says it's nothing, great, listen to your doctor. Right, but don't think that it's only numbness. That's the saying I hear so much from patients. Well, it's only numbness, so I don't need to worry about it. And I'm like, oh, if it's numbness, we should absolutely look at it.
It doesn't mean you have to do anything. It just is your body's telling you something. You check it out. Maybe it ends up being not a big problem, but if it is a big problem, you certainly don't want to ignore it because it's just the tip of the iceberg sometimes. So
absolutely. Okay, so last couple of questions. So what is your favorite maybe procedure that you like to do that you feel like can be the biggest impact on patients' lives? That you say, like, people come in and then after the procedure, it's like one of the best rewarding, fulfilling outcomes.
What's interesting, it's never like the procedure. So it's really about the fit of the procedure to the patient. So because if the procedure itself is well selected for whatever the patient has, like that always, it makes me happy. So if the patient's happy, that as you I'm not that far along in my career, but I'm already at the point where it's very important to me to pick procedures correctly because that having that impact on the good side versus not having any change after surgery is a big difference in terms of how I come away from it. So there are surgeries that in well-selected patients always work, right? So if patients have spinal instability, if they have movement because their discs have degenerated and their facets have disease, and so they're not competent, they're not holding their spine in alignment, then when you fix those people, even though it's with screws and rods, and usually people balk at, oh my gosh, I don't want to have a fusion, those are excellent surgeries for patients that have spinal instability.
Absolutely.
If patients don't have spinal instability, those are usually not great procedures and end up causing a lot of pain, and there's a long recovery, and you haven't really gained the benefit. Whereas if you have instability, then the screws and rods immediately fixate that instability, and a lot of that pain goes away pretty quickly. Another procedure that I do that's very gratifying is a procedure called a microvascular decompression for patients with trigeminal neuralgia. Again, in well-selected patients, it's an excellent procedure. But if you were to start doing that procedure on everybody with facial pain, it wouldn't work well, and a lot of the patients wouldn't be happy because there's lots of facial pains that are not trigeminal neuralgia. Absolutely. So again, it's about, as long as you select the patient well for whatever surgery, then you end up pretty happy. And there's not one surgery, let's say, that I really love. It's when I know that it's the right surgery that's when it feels good to do it, because you feel like, okay, this is making a difference.
I actually think this is one of the things that makes you such a good doctor. And one of the reasons we love to send to you is because of exactly what you said. There's a saying that says, if you're a hammer, everything looks like a nail. Right? And one of the things we hear about from patients that are afraid to go see a surgeon is they say, well, if I go see a surgeon, they're going to recommend surgery. Well, that makes sense, right? Logically. But at the same time, what the great doctors do is they're going to say, you don't need surgery, or you do need surgery, but it's exactly what you were just saying. It's matching the right procedure to the condition to get the optimal outcome. And I think that some people get comfortable doing their procedures and they're going to lean towards that more, but I think that the best doctors are going to really try to stay open-minded to say, how do I match the right procedure to the right condition so that I get the best outcome? And that's something you've done incredibly well, and we've seen that. One of the procedures that we love that we actually get to coordinate sometimes on is neuromodulation, specifically like spinal cord stimulation. and kind of tying some of the things we've already talked about, doing that in the diabetic neuropathy patients, right?
Yeah.
The painful diabetic neuropathy. And one of the reasons we've loved to see that is because when you're dealing with pain, there's a lot of different options that are there. But when you're dealing with diabetic nerve pain, it's really hard to treat in some of the classic ways, right? So if you try to do, you're not going to do much with physical therapy or chiropractic. It's not really there, right?
Yeah.
So then we go to the medications, and you've got gabapentin and Lyrica and all these different medications that are supposed to treat nerve pain. But what we've heard is the side effects for those are often people can't tolerate them, right? I think the research shows that something like 80 or 90% of people will stop those medications within a year because they can't tolerate the side effects. And so if you have a patient that's having diabetic nerve pain and they've tried those conditions, usually at that point in time, they're starting to lose hope.
Yeah.
Because it's like, well, you're just going to have, if these don't help, you're just going to have to live with it.
Right.
And one of the things that we loved about neuromodulation is for the first time, these patients that oftentimes had just lost hope of ever being rid of this nerve pain that they were having in their hands and feet, we were able to come in, we were able to evaluate them to see if this is the right procedure for them. But ultimately, if they were, we saw incredible success with dealing with something that there's not a lot of other things that deal with it well. We're seeing 80 to 90% of these patients getting 50% or better relief from that type of pain. What's your experience been with neuromodulation for diabetic nerve pain?
Yeah, I think it's been great. I agree. I think it's a very pure type of nerve pain where you're not dealing with other, arthritis or other myofascial or other pains that the stimulator maybe is not the best thing for. And so I think I agree. It's a great target. And the other thing is that it's amazing. It's the one condition where I think in the original studies that were done, they showed that they actually had improved sensory perception. So not only was the pain better, they did have a demonstrable, functional improvement.
Decreased tingling or numbness. And
better 2-point discrimination. Like something very objective where the patients had better 2-point discrimination with the stimulator. So what I take from that is that if you can, suppress the pain or suppress the effect of the dysfunctional nerves, then you can actually get the ones that are still remaining to work better. And so to me, that was the first time that something like that's been shown for neuromodulation, especially with spinal cord stimulation, something where you can demonstrate an objective improvement.
And one of the things I love about that is these patients, what we see as far as quality of life is incredibly debilitating, right? Because what happens is they have this pain and numbness and tingling in their hands or feet, and other modalities didn't work for them. And so their option now is okay, well, I'm not going to walk as much because it hurts to walk. And they begin to see their quality of life go down. They don't go out with friends. They don't go play with their kids or their grandkids and everything like that. And for me, that rewarding part that I was talking about is you do this care and they're like, for the first time I could feel the cold floor in my bathroom, and how life-changing that is for I haven't felt the floor in 10 years, or I was able to go out and go on a walk with my friends that I haven't been out and I haven't seen in 5 years. And so to me, yes, I love the fact that we're able to decrease people's pain. And anytime patients come in, decreasing pain is an important objective. But the more rewarding part is when you hear about how they get to do the things they love again, and they come back and they say, I can actually love life again. And that's, to me, the best part of what we do.
Yeah.
Right?
Yeah.
All right. So as a neurosurgeon, one of the most trending popular topics kind of online is brain hacking or trying to live longer. Longevity is becoming this huge space.
Yeah.
Cold plunging is becoming popular. You talk about cold shock proteins, heat shock proteins and stuff like that. Is it real? And what are some of the ones that you feel have a good basis in research?
I never like to make too far speculations on things that I really have no business, because I don't have a sort of sufficient background information. But the idea that you could do, the idea that you could expose your body to environmental stimuli in very concentrated ways, like a cold plunge, or in very rigorous ways, and have a neuromodulatory outcome, something that then changes your nervous system. I think there's certainly a basis for that happening. In general, this concept we call neuroplasticity. That is how plastic our brains are to rewire or to have functional changes that are lasting beyond a very short window. It becomes limiting as we get older. So in children, and even smaller than children, infants, lots of plasticity. So lots of ability to change their environment and have a long-lasting effect on their brains, which is, again, all the importance of child development, why that is such an important thing in early life. As we get older, maybe as part of a protective mechanism, our brains become much harder to change with changing environments. So maybe if you come up with some algorithm that does that in a very sophisticated and very rigorous way, perhaps there's like some hack that can actually have a long-term result. So conceptually, I could see that possibility. It's just very hard to do in a mature nervous. Yeah, it's hard to do in a controlled way. It seems like a daunting task in a mature nervous system. And then I think it would be very hard to prove. The degree of control you would need in sort of that experiment.
And everything. So what about this? There's a law on supplements for memory.
Yeah.
What are your thoughts on that?
It's the same. Again, if there's good evidence for it, you show me some, either like some good randomized controlled trials that are well done, or observational studies in lots and lots of people that don't have confounders. Those are the things where it's just so hard to weed out, confounding effects from what that supplement may actually do. So
you just triggered something in my mind. So what are your thoughts on placebo?
Yeah, I think placebo
and how it works.
Placebo is real. It's a clear phenomenon. It's something that is why we have to do very well-controlled studies to actually know if something works. It's nice to have placebo because in the end, you get a good effect, whether it's from what you thought it was or whether it's your internal kind of brain working. So, but yeah, placebo is based in the brain. There are studies that show that you can block the placebo effect by blocking. You can block some forms of placebo in certain experiments with opioid antagonists. So at least part of let's say in the
you're going to release endogenous opioids because you believe it's going to work, and then if you block that, it can't. Yep.
Right. Mm-hmm. So in the pain space, there's lots of forms of placebo because your brain can do lots of different things. But if you're talking about pain, then you can give patients, something that you say this will help your pain, and 30% of them, that's roughly I think that's about the placebo fraction. About 30% of them will have improved pain, even though all you gave them was like a sugar pill. Mm-hmm. But if you give them, the sugar pill with another pill, and let's say you give them 2 sugar pills or you give them 1 sugar pill and 1 opioid antagonist, then you don't get nearly as much placebo effect. And so, and it's there seems to be brain areas that light up during the placebo effect, and you can block those with opioid antagonists, and you can block the placebo effect. So all that goes to show that placebo it's a real thing, but it's just our brain's ability to do it itself without the external chemicals.
To me, that's awesome though.
Yeah.
Like the very fact that we're trying to develop procedures, we're trying to develop different chemical compounds and stuff like that, where in reality, if your brain believes you're going to get better or believes you're not going to get better, the effect on an actual outcome is massive. Right? And so I feel like sometimes we look at placebo in the research setting of being placebo means that it didn't work or did work. But now as research has advanced, it's actually placebo has this real measurable effect, and now they're trying to create, just as you said, processes to block the placebo effect so you can see the real effect of a medication and stuff like that. And I think in life that actually is really amazing, of the power of belief, that it's measurable in that way. And in healthcare, I believe it's really important that patients need to believe in their provider If you're not in a place where you believe that your doctor is going to help you, you need to find a different doctor.
Yeah.
Not because they might not help you,
Right.
but because belief is such an important factor in healing and in compliance. If a patient doesn't believe what the doctor says, they're not likely to do and follow the doctor's instructions, which means you're going to get poor outcomes. Right? So I believe that it's really important, one, to believe in your doctor. I believe, two, it's really important to understand why you're getting a certain procedure, so that when you understand why it's happening, you're much more likely to be able to be compliant, one, but two, believe that it could help.
Yeah.
And that belief that it could help is not going to hurt you. Like, it's measurably going to help you if you believe that it could help. And so, to me, it's just one of the most fascinating areas of research. And since you obviously are a researcher as well, I just was curious to hear your thoughts on that.
Agreed.
So, last two questions for you. One, what is something that maybe people don't know about you that is a hobby or something that you like to do that's just interesting about you? Most people don't know their doctors, and so I just think this is like a really good question of, like, you know, what's something you enjoy doing in your off time?
My favorite thing to do is just to hang out with my kids and my wife. So yeah, when I'm free, it's just family time. So we do on the weekends. I try to fill it up with activities, you know, to their, you know, sometimes to their dismay, because sometimes they just want to have a relaxing weekend at home. And like, to me, it's like, we got to do something, because, you know, I those moments are precious. But I'm realizing that sometimes it's good to just sit on the couch together. And but the point is that I try to spend every minute I can when I'm at home with them. Yeah. So
I think that's so important, and I find myself struggling with that as well. Is, you know, if you want to be successful in your career, it takes a lot of energy and effort, and it's so easy to come home at the end of the day and just be like, I'm exhausted. Yeah. And to not make time for that. Yeah. But how important is it to make sure that, you know, we take that time while they're young, while they want to be with you, while they want to do stuff with you, and to make, you know, we work so that we can provide for our family, but then if we don't actually spend time with our family, why are we working? Right. And I think that's, you know, a really wise answer that you're giving of taking that time. It's not about hobbies, about you and that downtime. It's about your family and spending that time together. Yeah. Okay, so last question for you. If you weren't a neurosurgeon, what would you be? I don't know. I'm not sure. I mean, the other thing that I do is do research. That would be an easy answer to kind of slip into, but I don't know that I'd be as satisfied. Like I said, the difference there is if I was purely a scientist, I don't get that same interaction and that kind of more immediate gratification. Science is often much more delayed gratification. You know, you're learning things that may help in the future, whereas, you know, every time I operate on someone, as long as it's, you know, like I said, a well-selected surgery for the right patient, then I'm going to help someone that day. So there's like a balance there and a trade-off. So to you, like, the most rewarding thing, it sounds like, about your career is that while you love the research and you're passionate about it, the actual rewarding stuff is changing patients' lives and actually being able to do that. So of course. That's fantastic. Yeah. All right. Well, again, Dr. Mirzadeh is at Barrow. He's one of the best neurosurgeons probably in the Western United States. Yeah, right. He's fantastic. Yeah, sure. We love working with him. Yeah. But again, thanks for coming on and talking with us today. For sure. Happy to do it.